they can't be alive outside. Just they produce the cyst form. The cyst, I told you, that's in the refrigerator in 4 degrees Celsius. They can alive for 1 month. But the trophozoite, I forget to told you the trophozoite in histological, the trophozoite and the cyst when pass through the stool, the trophozoite degrades rapidly. The trophozoite can't be infected. If we eat the trophozoite, they degrade in our stomach because of the acidic pH. So in the infectivity or spreading of the disease, the trophozoite isn't important. Just the cyst form, because of the cyst wall, which is very thick and it is cellulose, it can pass through the stomach, go to a small intestine, they rupture, excision happen, and the trophozoite come out and go to. So the infective state just is the cyst form, not the trophozoite. The trophozoite degrades rapidly. But the free-living amoeba, in the free-living amoeba, they are very resistant. They are live in the outside in the environment, in the water, but accidentally can infect our body and produce the disease. The most important one is acanthamoeba. Acanthamoeba can infect eye, skin, central nervous system. So different places, yes, eye, skin, and central nervous system or brain. They can produce encephalitis, they can produce skin grammatos, and also in the eye they can produce keratitis, inflammation of the epithelial cell of the cornea. It is very widespread. Every places here we have acanthamoeba. The most distributed free-living amoeba in the environment, water, soil, hot stream, all of the places can infect it with acanthamoeba. It can, in the keratitis, specifically when we use contact lens, soft contact lens specifically, sometimes hard contact lens can be infected, and when we use it in our eye, it can infect and induce keratitis. And also in the wound, if we have a cut, acanthamoeba can penetrate to the skin and produce a skin grammatos. And also about the brain, we can breathe it, and through the lung, it can, thank you so much, it can infect our CNS. So for your exam, in this slide, it is important that it can infect different places, such as eye, skin, and central nervous system. You can see that I told you acanthamoeba is very common in the lake, swimming pool, tap water, heating, air conditioner, every places can be infected. It has two forms, the trophozoite and the cyst form. It is attached, but it is one, unicyst. This is the cyst form, it is a star shape. And it has 2 layers, and because of these 2 layers, it is very resistant to different pH, different temperature, different osmolarity. So it is very resistant, and because of this resistance, it is most widely distributed. You listen to me, or you write it, or you check your cell phone, what's happened, just to you. من برم اصلا به تو وایس بدم.
همراه که تونستی نیست کنیم.
جدی میگم. از تهران دارم تصور میکنم. حالا الان با دکتر زیادم صحبت میکنم. ما ببینم ما باید واقعا بلنشیم بیایم یا چیز باید برقصم. منظورم که نرفتم شغل شما رو بکنم چون because the head of your faculty is here and I think maybe he lives here. I thought the problem. Oh, we have the trophozoite and the cyst form. The trophozoites have acanthopodia, totally different from the parasitic amoeba. The acanthopodia is a C shape and they produce a cyst form, and because the cyst form have 2 layers, they are very resistant. And about the spread, these are in the environment. How it can infect our body. It's not for human, but accidentally can infect us. For example, when we cut or broken the skin, the acanthopoda can penetrate to the skin, and also we can breathe in. It can infect our lung and go through the brain and produce encephalitis. And also, in the especially in contact lens wearer, it can infect it can contaminate the solution of contact lens, and when we use it, the acanthopoda can attach and produce inflammation in the epithelial cornea of the epithelial cornea. So we have different diseases of acanthopoda. So you should memorize that because today I speak about 2 amoeba, 2 free-living amoeba, acanthopoda and Naegleria. In your exam, you should know these items. Acanthopoda produce trophozoites and cyst form in our body, in our tissue. They can infect different organelles, for example, eye, skin, brain. In the neck area, I teach you in the next slide. About acanthopoda keratitis, in the eye, they can produce AK, acanthopoda keratitis. They can attach, this is the eye, this is the cornea, this is eye. We have the epithelium, this is the cornea. It's very thick. They can attach, they can penetrate to the stoma of the cornea and produce acanthopoda keratitis, inflammation of the cornea. In the skin, they can produce skin granulomatous, because in the skin they produce some nodular or granulation, and also in the brain they produce granulomatous amoebic encephalitis. They can produce encephalitis, they can penetrate to the brain, they multiply, they digest it, they digest it, phagocytes our brain cell, produce inflammation, and because of that we have encephalitis. But the disease here is chronic. It is important for your exam. It is chronic and produce granulation. Because it is chronic, they produce some granulation in the brain. Okay? The nature of the disease is chronic in the skin and in the brain. So because of that, we say granulomatous amoebic encephalitis. So in in the eye we have acanthomal keratitis, infection of the epithelial cell. It is specifically in healthy individual. The immune system is not important here. In the cornea, the immune system isn't important. Using contact lens is important. The trauma is important. For example, something you swimming in the lake, in the, for example, sea, something go to your particle, a stone, everything go to your eye, you rubbing rapidly your eye, and because of that, when you rub your eye, there are some trauma. The intensity of epithelial cell is reducing because the epithelial cell of the stroma is very tight. It's very tight that no bacteria can penetrate. But when there is a trauma, sometimes the integrity is reducing, the tight junction is open, and the microbial agent can penetrate. So don't rub your eye. Just use eye drop, or when, for example, especially something in your eye, don't rub your eye, because when you rub your eye with the stone, you're rubbing your epithelial cell and produce these some trauma, and any microbial agents can penetrate and produce inflammation. Keratitis, if you have experience of keratitis, most of the times we have viral keratitis, bacterial keratitis, fungal keratitis. Acanthomal keratitis is very rare, but very mostly happen in contact lens wearer. And nowadays it is increasing because in many society, especially developing country, most of the times female use colorful contact lens, and it's like changing our culture. I don't know what's happened to our female, but because most people like to change the color of their eyes. I don't know why. They use this color contact lens, and sometimes when with these very cheap contact lens, they are mostly, when you buy it, they are already contaminated with acanthomal. We have some patients just use one day, and after using 1 day, they infected with acanthomal. And most of the times when we use contact lens, gradually the integrity of the epithelial cell is reducing. So it is better that don't use contact lens, use glass instead of contact lens. Or if you want to use contact lens, use the most expensive one. And the handling of contact lens is very important. You should wash your hands, use antiseptic. You should have a very specific table for that. You should wash it. If you can use applicator, don't use hands for using contact lens. When you use contact lens, you shouldn't wash your face with, or you shouldn't go to bathroom because the tap water can infect it with acanthomal. Acanthomal has the cyst form, has 2 layers, and because of these 2 layers, it is very resistant, and the color that we use in tap water is very little amount, because if we use the higher milligram of the color, it has side effects for our body. Because of that, they use the amounts that's not toxic for our body. But this trace of amount of the color that's used for tap water or swimming pool can't degrade these cysts. Okay. or when you use contact lens, you shouldn't sleep with that. When you sleep, it is very dark, and every non-microbial agent can attach and the contact lens in your cornea. It has a very good environment for the microbial agent that can attach, and definitely if you sleep with contact lens, tomorrow you have redness, and most of the times have keratitis and infection, viral, bacterial, or fungal, or acanthamosis. It is, I told you, this prevention for all of the infections or microbial keratitis that you should pay attention. So you should know it, for example, as acanthamosis keratitis is, the risk factor is contact lens and trauma, not immune system. But about the skin gromatosis, about GAE, the risk factor is immune system. It is more prevalent in immunodeficiency patient, HIV positive immunodeficiency. So the risk factor is immune system deficiency. But acanthamosis keratitis, it is not dependent on immune system. Okay, just memorize it for your exam. Also, we have disseminated when more than one organ is infected, it is disseminated for. For example, when the patient has a skin gromatosis and also GAE, or also, for example, liver, we say disseminated infection. So also we have lung infection, but also we have disseminated. Disseminated is more than 2 organelles. So all of these are in immunodeficiency. In acanthamosis keratitis, that we have it, for example, in Iran and also in Middle East, we have acanthamosis keratitis in healthy individual and in contact lens or after trauma, infection of the cornea, and sometimes this is, you see, this is a ring shape or a white ring shape appearance of the cornea. First of all, just we have pain and redness, and after that, blurred vision, sensitivity to light, and gradually they can penetrate to the stroma, the deeper layer, and in this situation, eye drop or any drug can be effective. So the diagnosis rapidly and correctly is very, very important. When the amoeba is at the surface of the cornea, we can treat it. But if the amoeba penetrates to the deeper layer, we can't, because the eye drop don't penetrate to the deeper layer. So if it penetrates to the deeper layer, we can treat it with the eye drop or the drugs. And in this situation, most of the time, we should cut the cornea, and we should transparent the cornea. The hallmark of the diagnosis of the acanthamosis keratitis that you should memorize is ring-shaped stromal infiltration. When amoeba penetrates to the deeper layer because of accumulation of the stromal cell, accumulation of the, or infiltration or accumulation of the immune cell, gradually there is some white appearance of the cornea that eventually, finally, it is like the ring shape. This is the end stage of the acanthomokeratitis, that's definitely when ophthalmologists see that, this is just specific for acanthomokeratitis, and they can distinguish. But in this stage, diagnosis is not helpful because we should cut it and transplant a new cornea. In the first stage, that it has just redness or eye pain, in this stage we should recognize that, and it is very difficult because at the first stage, all of the keratitis is very similar. The symptoms are very similar, but we have some diagnostic tools that we can distinguish. Also, we have GVE. So this is in healthy individual. All of the tools that help me to بمیرم و فوت کنم بیفتم اینا چیه گذاشتن اینجا من لازم بیفتم. About the GAE, the other most important thing is GAE, or grammatous amebic encephalitis. Acanthomoeba can infect our brain with different ways. For example, we can breathe to the it can penetrate to the nasal root and directly go to the brain. Also, we can breathe it, go to the lung, and after that penetrate to the vessel, go to the brain. The other way is it can penetrate to the cut or broken vein or wound and penetrate to the bloodstream and go to the brain. And in the brain, they multiply, they phagocyte the brain cells and produce encephalitis, produce inflammation. But here in the acanthomoeba, the inflammation is chronic, and because of the chronic nature, they produce inclusion body or granulation that we can see it in the CT scan. And because of this granulation, the scientists name it grammatous amebic encephalitis. So based on the granulation, we should know that GAE is induced by acanthomoeba. I don't want you to memorize these symptoms. Okay, just know about the chronic GAE and this granulation. Okay, because they are similar, all the encephalitis, the symptoms is very similar. Don't memorize that. About the skin granulation or skin infection, acanthomoeba also can infect the skin, and in the skin they can produce granulation. If we have take the biopsy from the skin, in the pathology section, they see these granulation. So the most important things that can help the physician, the pathologist, for diagnosis is inclusion body. Inclusion or not inclusion body, granulation or inclusion. The other form is disseminated when more than one organelle, for example lung, skin, both of them, or brain, more than two organelles when infected, we say disseminated. And the most important things for your exam, you should know that all of them is in immunodeficient patient. Okay. In normal people, it's very rare. About the diagnosis. Because it infected different organelle, based on the organelle they can infect it. For example, for lung, we can have a specimen from the bronch. For GAE, we can have a specimen from cerebral spinal fluid or CSF. For skin, biopsy from the skin. For the acanthomoeba, we can biopsy or takes a scraping from the cornea. And after that, when the specimens come to the laboratory, they can culture it. They can use PCR or molecular method. Nowadays, PCR and molecular method have a very high sensitivity, like the corona, COVID-19, if you remember, we do real-time PCR, and also we can use culture for diagnosis. But it is important in that in the pathologic section, we both have trophocyte and cyst in the tissue. In the tissue, they have trophocyte and cyst form. And it is important because the cysts have 2 layers. The treatment of the disease is hard because the drug should penetrate from 2 layers, and because of that, the time of treatment is very prolonged. Sometimes 6 months, 1 year take to treat the patient completely. Fortunately, because this is free living amoeba, it is not for us, it is in the environment. And these forms are in immunodeficient patients. The number of disease is very rare. Mostly we have acanthamoral keratitis, and also it is lower than, for example, viral keratitis. About the treatment for escherichia we use fluoxetine. For GAE we use mifepristone. But about the keratitis that we mostly have this one, we use clonpamidine, isotretinoin, but the 2 drugs that nowadays routinely used is polyhexamethylene and chlorhexidine. These are very helpful for diagnosis of for treatment of keratitis. About for your exam, just if you remember this one, it can be helpful for you. About the treatment, please pay attention. Maybe I ask a question about the treatment of the acanthamoral. The other free living amoeba is Naegleria fowleri. Acanthamoral have different species, but most of them can be infected. Because of that, I don't. I told you acanthamoral is species. I don't want you. I don't write it down for you the name of the species. What about the Naegleria? Just Naegleria fowleri can be fatal in human. Other species of Naegleria aren't pathogen for human until now. The species that just can be infected, just can be pathogen is Naegleria fowleri. So about the Naegleria fowleri, the most important is that for example, it has 3 shapes: flagellar, cyst, and the trophocyte. In the tissue, we just have the trophocyte. In the tissue for Naegleria fowleri, we have the trophocyte. Although they have the cyst form, they have flagellate form, they have the trophocyte, they have pseudopodia, they have the amide form, but in our body, when they penetrate to our body, in our body, they just have the trophocyte form. They produce the disease. The disease that they produce, just they infect brain. The disease is acute, but here the disease are chronic. Okay, It is acute, very fulminant. Just infect brain, but acantoma have different organs. They can infect the skin, lung, cornea, everywhere. So you should compare it with this. This is brain. In acantoma, in the brain, they produce GAE, which is chronic, and which is produce granules. But here, Aponegnaria fowleri in the brain produce the acute infection, which we say PAM, P-A-M, primary amoebic meningoencephalitis. This is primary means acute. You can take a photo from there. After I finish, we'll take a photo from this. So about the Naegleria, you can infect brain. So for your exam, I ask a question. Maybe you should compare these two free living amoeba. It is very simple. It is also the Naegleria fowleri, as it is free living amoeba. They are in the fresh warm water, in the soil, in the lake, in the hot spring. All of these acantoma and Naegleria, they are thermotolerance. They can live in hot spring. Naegleria fowleri, fortunately, we don't have in Iran. And Middle East, but we have it in Pakistan, also in USA, in Texas, we have it. Because the disease is very acute, very fulminant, when we infected with Naegleria, after 1 or 2 weeks, the patient died because it's very acute. So what's happened about the infection? It is in the water. This is amoeba. They can produce the flagellate form, and also in some situation they can produce the cyst form. The cyst of Naegleria has just 1 layer, but the acantoma has 2 layers. It is more resistant, but Naegleria is sensitive. When the patient swimming in these waters, and Naegleria penetrate to the nasal cavity, here they can attach and they can directly go to the brain from the cariform plate, and after that they penetrate to the brain and produce primary amoebic meningoencephalitis. The incubation time is less than 1 week. The time of the symptoms or clinical symptoms just take for 1 week, 4 or 7 days, and after that the patient most of the times die. This is the autopsy, the section of the brain after the death. These are Naegleria, these are the trophocytes. We don't have any cysts in the acantoma. We have trophocytes and cysts in this tissue section, but in the Naegleria, in the section, in the section of the pathologic section, in the pathologic section, we just have the trophocyte, but they have 3 forms. They have 3 forms. They have 2 forms. But in the section, we have the just trophocyte. We don't have any cyst form. This is in the culture. These are the lobopodia or pseudopodia of Naegleria. I don't want you to memorize the symptoms. I omit that for you. Just you should know that they are in the swimming pool and it can infect directly the brain. But in acanthomobile, we have different routes for the infection of the brain. But in Naegleria, it just directly through the brain, and we should swim in the water. So from the water, the amoeba can penetrate. Because it is very lethal in America, in the lakes that infected with Naegleria, in the summer they forbidden for swimming. Because they are infected with Naegleria. If you search Naegleria, Texas, you can see the clip and video of the patients that infected with Naegleria. Fortunately, it's very rare, but in CDC or World Health Organization recognize the endemic region, and the swimming in these waters are forbidden because it is very fulminant. About the treatment, different, you know that in the encephalitis, because it is in end stage of the disease, physicians use different drugs that can survive the patient. So different drugs can be used. I don't want you to memorize the treatment of the encephalitis. So don't memorize them. About the diagnosis, I don't ask a question about the diagnosis of that. So don't memorize these, but you should know that in the pathologic section we have the trophozoite. But because in your these are the items of your curriculum of your class, I teach you. We can have a CSF because it just infected the brain. We prepare the CSF, cerebral spinal fluid, and we can stain that, we can culture it, we can use molecular method, immunocytochemical methods, or we can use hanging drop. In hanging drop, the trophozoites, we use CSF, we add water to CSF, and if we have an amoeboid, they transform to flagellate form, and we can see it under the microscope because I told you the Naegleria have 3 forms. Yes, they have the flagellate form. This is hanging drop. But I don't want you to memorize that. Nowadays, they just use molecular method. Molecular method is very rapid, sensitive, specific, and you see that in COVID-19, real-time history is very useful for diagnosis. And also the physician, I told you twice, the physician that's live, or if you go to Pakistan or any places, you should know the endemic region of the disease. For example, if the patient have the background of swimming, for example, in the infected water, it has a tips for you to suspect for encephalitis of Naegleria. Or also about histolytica, I told you. Because we have 3 sessions, we have so many parasites. I know that.